he was going to be highlighting the importance of eyes in global health and also the importance of refractive care within eyes. And Paul was a wonderful guy. I mean, he just was a nice person. He was compassionate, he was passionate, and he really cared. And he really changed the paradigm of global health in a way of focusing big public health issues on the individual patient. When Paul started, a lot of people were saying it's impossible. There's too much to do. Let's start with just getting clean water. And Paul said, no, these are people in Haiti. We need to do everything for each individual person. And let's make it cost effective. Everybody's important. When he started working in HIV, he really changed the paradigm. The World Health Organization's approach was basically give everybody a condom and prevent the spread. We'll let everybody who has HIV die, and then there won't be any more HIV if the people don't spread it. And Paul really changed the paradigm, saying, hey, every individual person is the most important person. And if it's too expensive right now to give antiretrovirals, let's figure out how to bring the cost down. The same thing with multi-drug resistant tuberculosis. And everything he did, it was both the grand scheme of how can we reach everybody, but also how can we do the best for each individual? And it really was social justice. And what Paul was going to speak about today were priorities in global public health and global health care and the need for nutrition and how we're dealing with every crisis from the current pandemic of SARS, COVID-19, to how we're dealing with multi-drug resistant malaria, maternal health, and childhood health. And one of the things he was going to conclude with was that within the realm of health, vision is so important. And when the UN Millennium Development Goals were brought out, unfortunately, vision wasn't included. And Paul was one of the very few advocates who were involved at the level of making those decisions who said we should have vision in the UN Millennium Development Goals. And now with the new onset of UN goals that are saying the overall well-being of a person is part of those health goals, vision actually has to be part of it. And really, vision is the low-hanging fruit of global public health. And that was going to be the conclusion of Paul Farmer's talk, which, as I said, for those of you who don't know, he died of a sudden heart attack in Rwanda about 3 weeks ago now. And I had actually spoken to him about this talk about 1 week before he passed. And his conclusion was going to be that there's an epidemic of global blindness, with 39 people blind, but 80% of that blindness being easily treatable or could have easily been prevented. And that 90% are in the poor places in the world. And the impact of people is devastating. And there are 19 million children who are severely visually impaired, who with refraction can live a completely normal, healthy, productive life. Another thing that really irks me when we see these large organizations and how we're getting funded, for example, the Gates Foundation says they're not interested in interventions in things that aren't life-threatening. But several studies have come out showing that once you go blind in the developing world, in the poor countries of our planet, life expectancy is 1/3 that of age and health matched peers. And Taylor published in Australia showing an increase in mortality when people lose their vision in Australia. And for blind children, it's worse. In blind children, the ones who go blind are usually in resource limited places where there's food insecurity and they have total caloric deficiency. And but the ones who go blind from vitamin A deficiency, among those peers who have the same nutritional challenges, the blind children die at a much higher rate. And the other thing that doesn't really get discussed enough is the economic impact of low vision and blindness, and people who can't function and work at a job simply because of a refractive error or because they're blind. And that actually takes not just that person out of the workforce, but also another person. And this often is a child who has to lead their father around by a stick and take care of their mother or take care of their grandmother, and they won't go to school. Or a child who has to go work in the fields at age 10 to feed their family in a subsistence agrarian economy and will never go to school, and the lifetime loss of earnings of that child because they can never work. So blindness really leads to and perpetuates poverty on our planet, both for the individual, the family, the community, and the country. So blindness really needs to be a priority. And when you look at the prevalence of blindness, you see that it really is centered in Asia, South Asia, and Africa. And one of the other big challenges that we have are those same areas are where we have less healthcare workers. Where David Chang and I live, we probably have an ophthalmologist on every block. In America, I think the statistic is now one ophthalmologist for every 18,000 people. But much of Africa, it's really devastating. But also there's a shortage throughout South Asia. I just returned 2 weeks ago from South Sudan, where there are 3 ophthalmologists for 12 million people. 3 ophthalmologists for 12 million people. And how do we figure out what are we going to do with our resources? What are our priorities? Well, again, the priorities have to be intervening in the low-hanging fruit. And what is the lowest hanging fruit? And I'll get back to it in a second, because I'm going to talk about some other programs, but the lowest hanging fruit is refractive error. The leading cause of what we would call in America legal blindness, 2200, is lack of spectacles or lack of refractive surgery. Cataract is then the next leading cause of complete blindness, and it's completely reversible. Glaucoma is difficult, but trachoma, onchocerciasis, xerophthalmia, these are public health issues that we should be able to really do something about. And it's just a travesty that those diseases still exist to the extent that they do. So cataract is the #1 cause of overall blindness. And I think we can learn a lot from some of our programs of how we've addressed cataract into how we can address refractive error. But cataract is refractive surgery. I mean, we're taking a lens that's not focusing, and we're changing the refraction and getting people to see. And certainly, the way we practice in America, I'm looking at. Hello? 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 Can you all hear me okay?
There's a little bit of an echo, Geoff.
It's just
you may have to go back out and back in.
No, Geoff, no, you're fine. I was able to fix it. It was one of the panelists that unmuted, and we're fine now. So
okay.
You can proceed.
Okay.
Everything's good. Thank you.
Okay, so in cataracts in children is one of the most efficacious long-term fixes that we can have. But as I said, cataract really is refractive surgery. Overcoming trachoma, it's really a public health issue. Getting clean water and azithromycin to every community. The same thing with xerophthalmia. It's just distributing vitamin A, and it's possibly the most efficacious intervention in all of medicine, 75 cents per child per year to prevent a child from going blind. And same thing, there are great programs for onchocerciasis. So let's talk about just refractive surgery now. First, the refractive cataract surgery. We need to give really good quality cataract surgery to all the people on our planet who can go from complete devastation of their lives to a perfectly normal life with a cataract surgery. And the joy is just palpable, and it really is, refractive surgery. And one thing that needs to be focused on, I think, in a lot of our programs in some of the lower resource countries is making sure the refractive outcome is similar to the refractive outcome we try to give to our patients in the more developed world. One of the other interesting things about cataract surgery is the ones who are totally blind are often ones who can't afford to pay. And when you start looking at the numbers, when you start operating at 2,200, you can see 2 lines down the eye chart, or what we in America give benefits for being legally blind. All of a sudden, it's 60 million people who would benefit from cataract surgery. And if you start operating at the level where I certainly start operating at Stanford, and when someone's having trouble driving at night, it's 8 times that number. But one of the things we've been working on doing is harnessing those patients who are still working, who can afford to pay. It's been called at Aravind compassionate capitalism. And we've spread that into Nepal, where paying patients are subsidizing the free care for the poor. And we have models where we're doing very high volume cataract surgery that's now extending towards the poorest of the poor. So the poorest of the poor get the exact same quality care, and it's being subsidized by the paying patients who can pay. And refractive care is really set up beautifully for that same kind of model of compassionate capitalism. So the 2 points from cataract surgery are how we can do high volume surgery, bring down the costs, and use the profits to pay for free care for the poor. And similarly, the cataract surgery has to be refractive surgery. And the WHO came out with a report on world vision in 2019. And again, you can see that the huge elephant in the room is unaddressed refractive error. And then at the bottom, you see unaddressed presbyopia. And there are about 1 billion people on our planet with visual impairment that could be better addressed. And there are also a lot of people in the lower resource countries who are having sutureless extracapsular cataract surgery, who are having induced astigmatism and not having their best possible vision because of refractive error. So just giving spectacles is a great thing. And how do we figure out, as refractive doctors and as eye care specialists, how do we figure out how to reach the most remote people? We need to figure out how to get a much better, more robust, and less expensive autorefractor, how to be able to bring in the ability to give these people spectacles. We need to do something much better for presbyopia. And as the population increases, these problems are just increasing as the time goes on, and particularly presbyopic issues, but also as we have so many myopic children who are moving into their teenage years and will be soon moving into young adulthood. And how do we keep them productive both in school and in life? And the World Health Assembly came out saying they want a 40% increase in coverage of refractive error by 2030 and a 30% increase in effective cataract coverage. 2030, that's a long time. I think, as Ashiana said, there's an urgency, and we really need to all work together and start doing things now. It's early in the morning for me, but do you guys know what time it is? The time is now. The time is now. And this is our time to really get together and see that every child in every poor country is able to get spectacles. And as people get older, refractive surgery does have a huge place, both for the elite of the country who are willing to pay to have their refractive surgery, but also as a way to fund refractive care. And it should be a completely integrated system in my mind, where we're giving refractive care people There's a wonderful system that Dr. Hewa I always forget how to pronounce his name. It's either Heiwei or Hewa in the Manchurian province of China, started a program where he has refractive clinics, and people can come in and they have both the spectacles available and the high volume LASIK. And when you're doing the refractive surgery, the profits, again, can go towards helping with the poor. And the first program that really set out to do that I know of was at our hospital in Kathmandu, the Tilganga Institute of Ophthalmology. We sent one of our young superstars, Kishore Pradhan, to London Vision Clinic, and he worked with Dan Reinstein, who really mentored this program. And the idea initially was to have high volume refractive surgery, have it available so that a certain percentage would be on the destitute, people who work in a area where they can't really wear spectacles, people lose their spectacles. So refractive surgery might be a great option for poor people, and that it would also be a great program to subsidize also all the refractive care and giving spectacles. It really did its job, but unfortunately a lot of the money, things changed in Nepal, and the Nepal economic situation mandated that we needed to use some of the money to support other aspects of the hospital. And it became very profitable. It did everything we wanted it to do except launch this huge refractive program intended to fund more outreach cataract surgery and funding of more nurses, and increased. It was right when there was a oil embargo, and Indian government blocked the trucks coming in from India, and prices of oil went way up. And unfortunately, it subsidized other things, but it really set the model and set the bar. And I really believe that we can use refractive surgery. And one thing to backtrack on, refractive surgery really is the low-hanging fruit. And there are huge numbers of, billion people who have refractive error. But when it breaks down, one of the ways Paul Farmer used to look at things, which I really admired, was that these are each individual people. And when we do LASIK for someone, they're no longer a statistic. They are 100% cured. They're not part of that 1 in a billion. It's one of the few things. Cataracts and refractive error are things where we can completely cure people. And people can see the beautiful views of their world. They can function, they can work. And I think it's so exciting we have this panel here today that Ashiana brought us, and with thanks to the ASCRS Foundation, and to be able to address and figure out how we can all work together to figure out how we can do something for the 1 billion people on our planet with refractive error. It's the low-hanging fruit, and it's something we can do. And I'm very sad that I'm giving this lecture and not my friend Paul Farmer, but his conclusion would be the same, that we have lots of work to do, and the time is now, and let's get her done. Thank you very much for inviting me, Ashiana.
Thank you very much, Dr. Tabin, for being with us. You have highlighted aspects that are going to be brought up in every thread of the segment part 1 and part 2. So thank you for giving us an appetizer to the interesting discussions that we're going to have ahead of us. I am now going to move forward to the next segment, which is a foundational talk and topic, and that is the current state of refractive error.